Welcome to Pediatric Grand Rounds. Today, our speaker is Dr. Laverty. She came to Carilion after completing her residency in internal medicine and pediatrics at the University of Tennessee in Memphis. She works as an inpatient attending in both medicine and pediatrics, as well as seeing patients in the adolescent medicine clinic. Prior to deciding to pursue medicine, she taught high school in Milwaukee, Wisconsin, and throughout her medical training, she has had a passion for advocacy work, specifically with the adolescent population, as well as an interest in medical education. She hopes to get more involved in the Roanoke community as her family makes Roanoke home. She joined Carilion in August 2023 and has made a significant impact in both medicine and pediatrics, the recipient recently of the Teaching Award from the Pediatric Residency Program. Please join me in welcoming Dr. Laverty.
Good morning. I'm very excited to be here today. So we're going to talk about contraception for the adolescent population, focusing on some misconceptions that are common with our adolescents, and then some provider bias maybe in our counseling and how we maybe can overact that. So I have no financial disclosure. In all transparency, part of this is an adaptation of a previous presentation I gave at the University of Tennessee with just some modifications and some new information added of our health equity rounds that was done there. So we have a lot to cover today, and so we will, here are our objectives. So kind of focusing first off, what are our kind of AAP and SAHM's recommendations on contraceptions when we're thinking about the adolescent population, then moving into what are the misconceptions or maybe more accurately termed misinformation that could be held by adolescents, and then looking at some inequities in our teen pregnancy rates and pregnancy and family planning and getting into some historical context of that to then think about how are we counseling. And, I think all of us, maybe our primary care physicians and as an adolescent clinic, we're talking about this on a daily basis. So all of our touch encounters with our adolescents, thinking about, how are they on contraception? What are their viewpoints? And if these do happen to come up, how can we intervene to maybe correct some misconceptions? So first, just our policies. So the American Academy of Pediatrics, here's some experts. I'm not going to read all of it, but I do just want to emphasize that, they believe that we should educate all patients about, all contraceptive methods that are safe and appropriate and describing the most effective methods first. And I'll have kind of a good refresher on what are our most effective and what are our least effective contraception tools. And then, specifically the long-acting reversible contraceptives, or LARCs, should be considered first line for adolescents. And this is because we're aiming at reducing adolescent pregnancy rates. And so LARCs, do not have those daily barriers of needing to take something at the same time or refill. They're just kind of placed and good for a set period of time. SAHM, or the Society of Adolescent Health and Medicine, and this is their statements as well. They again emphasize the universal access and that counseling should be evidence-based, confidential, and culturally sensitive and developmentally appropriate, with LARCs being first line again, and just a really strong emphasis on shared decision making. And I think the adolescent population can be difficult. We've had a lot of conversations in our clinic upstairs trying to focus on making sure there's non-coercion, that we're not forcing someone or an adolescent into a contraceptive choice and giving them the right medical information, but still maybe able to express the facts in a way that they don't feel forced into the decision they're making. So this is just, today's talk is not focusing on what are the different types and how do they work, but I do just want to kind of refresh our memory. So again, with the top of the dark pink, this is from ACOG, being the most effective contraceptive tools, so less than one pregnancy for 100 women in a year. So that's going to be your implants like the Nexplanon, the IUD, so both hormonal and the copper, and then tubal ligation or sterilization. And then the next kind of tier are more like your hormonal options, like the depot injections, pills, patch, going to be around 6 to 12 pregnancies for 100 women in a year. And then the least effective will be like condoms, natural family planning, spermicides, just to kind of keep fresh in your memory. And then this just quote is something I just want to kind of leave in, as we kind of have you just take in as we go through the next part of the presentation. And so just think, with birth control, while there is a first line in terms of recommendations of thinking about LARCs for our adolescent populations, being cautious with equating, our pregnancy prevention with heart disease, and that this truly is a shared decision making. So not just equating this, keeping the patient involved in the decision that they're making. So next we're going to jump into some misconceptions held by our adolescents surrounding contraceptions. So Where do teens get their information? So friends and family, obviously, right? Word of mouth, school programs. So we have Brooks upstairs who does a wonderful job, getting into our school programming and education. But then schools themselves often do school programming. And then thinking about, depending what state like you might be practicing in, you might actually be limited. So in Tennessee, we were abstinence-only sex-based education. So we weren't allowed to mention any like contraceptive methods. In the public health agency, so this would be more like your Planned Parenthood or things out in the community that might be putting on events that others could go to. And then social networking sites is going to be kind of a focus for this section of misconception. So this has been a very strong rising of as social networking sites has become just infiltrated in not only our adolescents, but our own arguably lives, thinking about how is this influencing people's knowledge and perceptions of these tools. And then I think, this last fact is just quite staggering if you think about it. 1 in 4 young people, again, this is above our adolescent population, more into the young adults that we still see upstairs, report pornography as their primary source for learning about sex. I would also argue like the doctor should be on this as well, right? Hopefully we're talking about this, taking this as part of our history and not just breezing over, but truly trying to engage, the adolescent in conversation about what are your knowledge about these tactics or just information in general. So the impact of social media, so this will be kind of the focus on the misconception. So each bullet point here is a different study. So this first study was in ACOG and it looked at tweets from 2007 to 2019 that mentioned any type of contraceptive. And what they found is that, there was a 300-fold increase in the span from 2007 to 2019 in tweets just mentioning contraceptives. What's specifically kind of interesting is in tweets that used just one method of contraception was mentioned, they then looked at was it a positive tweet or was it a negative tweet? And they found that the majority were actually negative tweets when just one method of contraceptive was mentioned. But then actually what's kind of interesting is that when a LARC or a long-acting reversible method was mentioned, it was 2 times more likely to be positive. So that's reassuring that, as like IUDs and Nexplanons are becoming more popular or maybe more commonplace or known or talked about, that we're actually seeing a more positive correlation, at least, in this study itself. The next study looked at, it was looking at YouTube videos and influencers, and so it looked at the top 50 views when they Googled birth control experience, and each viewer, they had to have at least 20,000 views to be included in this study. And of the influencer views, the average following rate, so this would be just your average Joe at home following and listening to the influencer video, had at least 370,000 subscribers. So it's a pretty wide audience if you think about it, they're reaching to. And so of those 50 top videos with birth control experience Googled in, 74% of them were actually talking about how to quit hormonal birth control, bless you, and find natural ways to prevent pregnancy. So it's pretty interesting, this is one shift we're seeing is maybe people advocating or pushing for more of a natural family method. When we think about our adolescent population, that might just be not something, that they can actually do with their schedules and maturity and understanding, but also there's other methods out there. And what are the concerns with the hormonal birth control, which we'll dive into. And then this last bullet point, this last study, it actually looked at TikTok videos. And so they looked at the top 100 videos for 8 different types of contraceptions. And basically what they found was first, there was very limited, only 20% of the videos about were actually made by healthcare professionals. Of those videos, what's reassuring is, 92% of the ones made by healthcare professionals were deemed educational, which is great. But what's scary is that, so then of the 80% that were non-healthcare professionals, 22% of those were educational. So what we're seeing is that people are kind of espousing maybe their opinions or their experiences, which are valid. We're not trying to take away from that. But also with the influencer generation, right, brands like are maybe influencing them to maybe say certain things or have certain opinions for their kind of influencing brand or their overall image to further their own kind of career. So I think really kind of thinking about the impact of social media, it's becoming a lot more prevalent in how our adolescents, what they're actually seeing on their social media. Contraception's being mentioned a lot more, which is wonderful, but I'm thinking about what are the implications of how it's being talked about, and is it in fact in an educational way or more of an experiential way, and then what does that influence, our adolescents' opinions. So I do, understandably so, Carilion does not have TikTok. We cannot access it on our website, but I did find a few videos just to try and bring, for those of you who may not have seen, just some ways in that our youth might be engaging with contraception. So it might be a little bit loud. And these are on YouTube that I could find to get through our Carilion network.
might change your pheromones, which are...
Let's see. So this one is actually, this is a Mama Dr. Jones, which I'll have as kind of a resource. She's actually wonderful. She's an OB-GYN that kind of takes some of these misconceptions.
Basically said being on hormonal contraceptives might change your pheromones, which are subconsciously influencing the partner that you choose.
So like that's like one thing that's like circulating around Twitter is that like if you're on birth control, like your pheromones might change, you might pick up your partner, and then when you go off the birth control, then your pheromones are different, and then you don't like your partner anymore, and then you guys separate and have marital problems, and it all is terrible. So that's like actually circulating around TikTok, and she's kind of dispelling this myth. So there are doctors on there like kind of dispelling these myths. This has been like a popular, so we'll just watch it. So this, she's trying to highlight that she like gained weight like before birth control, she was thin, and liked herself afterwards, she gained weight. This is the kind of mood and just being really sad, and this just goes on and on. This song gets really stuck in your head, so. And then the last one, again, just for the sake of time, we'll show one more.
No, I can't do that. No, I'm not doing that. I'm sorry. Oh, no, I can't do that. No, I'm not doing that.
So again, those are just some snippets of ways in which birth control is being perceived in like the TikTok community, and these are ways that our advocates are engaging and getting messages about contraceptive use. So thinking about then, what are the impacts of some of these influencers? So this is that study that looked at like the top 50 videos when we look at birth control experience. So again, an averaging of like 370,000 subscribers, and each video had at least 20,000 views, with the most having like 2.2 million views. And these were just reasons that the influencer, when they actually transcribed and then looked at like qualitative coding, reasons for discontinuation. So most were like being more natural was the highest, and then there's just kind of a plethora of side effects that we probably have all acknowledged when we've taken care of our adolescents or young adults that are on birth control, you may have heard about. But I think what's more interesting is if we look at what are the influencer side effects after stopping. So those same people, when they talked about, what happened after they stopped their birth control. And what you can see if you look holistically is there's quite like contradictory, things. Some people's increased energy, some had fatigue, some had improved mood, some had mood swings. But I think what's really like consequential when we think about our adolescent population is if you're looking at this video in just like a one-time event, you might not see that, well, this is more maybe experiential for the individual rather than like data or fact. And they're taking it because they see these influencers as someone that's, more like a peer, relatable, accessible, that they're taking it as, this is just kind of fact and that's what happens, rather than maybe the whole picture as, well, that happened to you and that was your experience, maybe it would be different for me. So a couple of misconceptions, just to hit some of those common reasons that people in our adolescents have concerns about birth control. So hormone-based birth control makes you gain significant weight. That'd be false. So there's two Cochrane reviews here listed below. So the first looked at combined contraceptives, and they actually found there was no significant correlation when looking at, they couldn't actually draw a conclusion that it actually led to gain weight or not, but there was no significant weight gain that they could actually contribute to it. And then for progesterone only, there actually has been more of a link with weight gain, specifically with the injections, but on the mean weight gain is still less than 5 pounds, it's less than 2 kilos. So again, there are studies though that women looking at perceived weight gain, they are perceiving that they're gaining weight while on these medications. So I think kind of exploring that and maybe doing some anticipatory counseling as we're starting these medications if that's what someone chooses. The next would be using hormonal birth control leads to infertility, and that would be false. So if we think about, this is a nice graphic, so no delay, when you're using barrier methods, a short delay with most hormonal birth controls, like being like 1 to 3 months, and then the longest delay is with the progesterone injections, and kind of, again, with our adolescent populations, most of them are not attempting to be pregnant, within like the next few years. But that's something that is a concern, being able to bring up, usually within a year, if you are on like the depot injections, you're able to have your ovulation return to normal and hopefully conceive if that's within your framework of desire. This one's kind of interesting. I don't have my fancy like false button to stamp on it, but birth control use increases depressive symptoms. And this is something that's very prominent on the TikTok videos. Kind of you saw like they're all happy and then they're just like crying and super sad after being placed on birth control. And the truth is there's actually studies that do demonstrate some increase in depressive symptoms in adolescent populations with OCP use. However, ACOG did release a study, this is from CDC here, that showed that there are no contraindications to hormonal contraception for women with depression, citing lack of evidence supporting an actual causal relationship. So maybe thinking about what else is going on in that, like is it just the adolescents as a whole, other things going on in that group? One study that showed a correlation with depressive symptoms, they looked at women 16, 19, 21, and 25, and when they looked at the data as a whole, there was no change in depressive symptoms, but only within those 16 years old, even if they accounted for race and socioeconomic status. So I think also kind of arguing there has been improvement with people on hormonal birth controls if they have premenstrual dysphoric disorder mood symptoms. So we are also seeing like the benefit from a mood disorder on hormonal birth controls as well. So long story short, in ACOG's kind of stance is that there's like maybe, further research needs to be employed to actually see like what is the definitive comment or relationship, but that we actually have studies that could go with ways we haven't seen a clear causal relationship between hormonal birth controls and depression. And then lastly, I just wanted to briefly talk on, I think this could probably be its own green rounds if, this is something that like adolescents tend to latch onto even further. But I have seen and I have heard in clinic, like the emphasis on wanting to be more natural. And that's, the influencers kind of stated, but kind of aiming towards a natural family planning. And so this is false, and I put the 99% accurate because there's actually a device on the market called Daisy, where it's a thermometer that you actually use, and then it uploads to an app to kind of give fertile window periods that claims to be 99.4% accurate. And so that study was actually retracted in 2019 because of concerns with maybe the methodology, but also how they're maybe presenting their data and their conclusions. And I do think if this is something that for some reason a patient's interested in, really emphasizing like awareness and education about how natural family planning works, the possible fluctuations in it. And then, I think the influencers, they don't actually, when they are promoting these methods, emphasize on, what are they using during their fertile windows, if anything. So I just kind of plugged that in there because it was something that seems to be kind of up and coming of the influencers advocating for, and something I've actually had patients inquire about in clinic, and I just think it's good for us to have in our forethought as well. So next, moving into some inequities in teen pregnancy rates and family planning. So here's our 2022 CDC teen birth rate by state. And what you can actually see is Virginia, we're actually doing pretty good for the states around us. We're at 11% of teen birth rate. So I just pulled the states kind of in our immediate geographic region for comparison. And then if we look at Roanoke Valley pregnancy rates itself, so the blue here is Roanoke County, city. The green is Roanoke County. And then this dotted line is Virginia, so our average. And you can see Roanoke City is still quite a bit above, the state average, and it looks like it's maybe slightly increasing, as well as Salem City itself, but the rest, tend to be slightly decreasing over this, 4-year period. But we think about inequities and then we think about race, and so what's quite interesting is there still is, this is older data, so looking from 2014, but individuals identifying as Hispanic or non-Hispanic Black having 2 times more the rate in 15 to 19-year-old girls with teen pregnancy. And so just inquiring or thinking, well, why is that? It's quite interesting. And if we look back to our Roanoke pregnancy rates by race, so the same data that I showed you before, but breaking down by race, again, we still see that disparity of individuals, that are Hispanic or non-Hispanic Black having higher pregnancy rates compared to our non-Hispanic white population. And so, in a study of family planning, it looked at women, and it found that women of lower socioeconomic status and women who identify as Black or Hispanic were less likely to use contraception overall and have higher rates of contraceptive failure and discontinuation. And so this is where, this part of the presentation jumps into maybe some historical context for maybe why is the reasoning or thought process behind some of this. So if we look back to just historical context of contraception and sterilization, so in 1907, Indiana passed the first law legalizing sterilization. And by 1932, 27 states had sterilization laws, and the era principles at that time were the progressive era, so one that looked and linked science to social problems often, and then eugenics, which is defined as the science of improving human population by controlled breeding to increase more desirable heritable traits. So Buck versus Bell was a case that actually legalized sterilization in Virginia, and this is just a quote from that case. And I think it's just quite staggering, and hopefully, I like to think our society has moved beyond this, but thinking, it is better for the world if instead of waiting to execute degenerate offspring for crime or to let them stare for the imbecility, society can prevent those who are manifestly unfit from continuing their crime. The principle that sustains compulsory vaccination is broad enough to cover cutting the fallopian tubes. 3 generations of imbeciles are enough, which is quite insulting on a lot of levels and problematic, but that was the thought process at this time that then further, led to policy and laws that have definitely impacted populations of individuals. World War II, the eugenics movement then became a lot less favorable, with the mass prosecution and murder of the Jewish population, but then led to maybe a thought of, well, for population control, we needed to be thinking about who's able to reproduce and how are they able to reproduce. In 1952, John D. Rockefeller, he established the Population Council, and then there was this book, The Population Bomb, so again, focusing more on population control and our concern for need for birth regulation. Title 10 was enacted in 1970 as part of the Health Service Act that tried to give incentives for individuals for low-income populations, like family planning services that otherwise couldn't afford it. But it tended to be probably punitive in some ways in terms of and people feeling coerced in order to maybe get tubal ligations that maybe wouldn't have. 1973, Rife versus Weinberger, this was a Southern Poverty Law Center filed a suit on behalf of the Rife Centers, who were 2 black teenage sisters who were mentally disabled, who mother just gave consent to get progesterone injections, and then they actually had tubal ligation without their consent. And then in 1975, Madrigal versus Quilligan, it highlighted Mexican-American women in California were being disproportionately approached and pressured to get tubal ligations. And then there's also been cases as recently as 2010 in the California prison, where again, women felt pressured after giving birth in prison to have tubal ligations or coherence without their consent actually being obtained. And I say all of this, kind of historical context to think about, who are being most impacted by these policies and feelings of coercion were, women of color and lower socioeconomic class. So the last part of this, verbose presentation is thinking about implicit bias and then thinking about our counseling considerations as we're taking the patient in front of us and trying to advocate for them to pick a contraceptive method that they feel knowledgeable about and feel comfortable applying. So without, I feel like implicit bias is kind of a buzzword these days, but just kind of naming that definition for the purpose of this presentation is truly just a prejudice in favor of against one thing. We all have them, we're all raised in them just by our experiences and the culture that we're raised into. Explicit bias being more of a conscious, self-reported, and hopefully it's declining in incidence over time as you maybe get called out on it or have different experience. Implicit bias, though, is a lot harder because as we go about, and grow up, whether it be rural, urban experiences, our own identity, they're just ways that we're perceiving and framing the world, and sometimes we may not even know they exist. And again, I just want to emphasize, not trying to place, judgment or weight on these, but just thinking that they do exist and that it impacts how we go about our interactions with people on a daily basis, and they exist for a wide range of topics. So I say that, because we're thinking about the patient experience of contraceptive counseling and how implicit bias might be impacting it. So this is, a telephone study survey that was sent out to English and Spanish-speaking Latina women, it was a telephone survey sent out to women who were called. And of women who were English and Spanish speaking, Latina women were less likely to give high patient-centeredness ratings. They felt that the provider did not really want to know what they thought or that they were comfortable with the contraception they chose. So whether that's purposeful on the provider's part or not, it's interesting that, by a language barrier potentially, that there was some difference in the contraceptive needs. And then Black women were more likely to feel pressure to use a contraceptive method compared to their white or Spanish-speaking counterparts. So again, it makes you think about what's going on with that provider, if it's the same providers, seeing the patients, that maybe one group of population might feel differently than another. Another study, so this is one of the few studies that I could find that actually looked at provider bias specifically. And so gynecologists were given different case vignettes, and it was like, who would you provide or recommend a tubal ligation for? And so they found that gynecologists were more likely to perform tubal ligations in women who were older, postpartum, purist, married, well-educated, and then Black, poor, and low income. And so in this study, what kind of makes sense is it makes sense if a woman's older, postpartum, you know, like they're probably maybe be done with their child-rearing years, postpartum, you're already maybe like did a C-section, so you could do the tubal ligation then. If they were married and had that decision that they didn't want to have other children, and well-educated, you know, maybe they had other options and they were stern, like, no, this is what I wanted. But the concern was then, why is there kind of this racial socioeconomic discrepancy, as well as the impacting their findings. And then lastly, I want to look at like our bias that might be present when thinking about our teens with contraceptive counseling, right? So that's our adolescent population we'll be seeing. And so a qualitative study, just looking at approaches to contraceptive counseling, actually saw that, you know, our younger population had more of a foreclosed approach. So that being that, you know, well, tell me what you know about contraception. And if they just list one thing, that's all I'm going to talk to them about as the provider, and that's it. Versus, you know, in our older population, we're getting the informed choice more likely, or shared decision making, which is more comprehensive. And so what we would argue, right, is that it's actually probably well, everyone needs, you know, more a shared decision making and comprehensive understanding and discussion about different contraceptive methods. But I would say our adolescents definitely need to know, you know, and be engaging in more of those detailed conversations rather than the foreclosed, to make sure we actually know what are the options, what are the risks and benefits of each, and how can they decide which one might be best for them. This next study then looked at focus groups and the possible distrust to providers, which I think is fair given some of our like social context and historical sterilization that we reviewed that might be pertinent, you know, when we think about our, especially women of color and lower socioeconomic status. So one provider said, you know, birth control makes me really weary because it was made to keep people like me from procreating. So, you know, obviously if someone feels that way and they don't trust their provider, or maybe they don't go to their provider a lot, so they don't have a relationship with their provider, it definitely could impact, are they choosing contraception and how do they feel about it? And then there was a white participant that, you know, felt that providers might be pushing long-term method more with poorer women. And again, not saying like, is this actually happening, right? But hopefully it's not. But thinking about if this is the attitudes and perceptions that individuals are having, it definitely probably is impacting their choices or their openness to conversations. And thinking about that as we're engaging our patients. And then, you know, we've covered a lot, and am I doing okay on time? Okay, so we've covered quite a bit, and so lastly, there's still a lot more that, you know, just for the sake of time in the conversation, we can't get to that definitely impact contraception as well. So we talked some about like side effects. We talked more about like misconceptions, but there's definitely, you know, there are side effects for birth control, and how do you navigate those conversations? Pregnancy desirability, I'll touch on in a little bit here, but there are adolescents that maybe want to get pregnant. And there's very complex, you know, conversations and history, but I've had patients that are aiming to get pregnant in their teens. And then thinking about, you know, I think Leah Birdwell with her screen time burn rounds a few weeks ago talked about like context was so important, right? Like of what's happening. And so I think context, again, when you're having both these conversations, but also their framing, and then both like sexual gender identity and then safety too. You know, are they in a home or in a place where they can actually obtain and utilize contraception as well? So the lastly are just thinking about some tools for effective contraception counseling. And admittedly, like in the adolescent clinic, we are so blessed and gifted to have a space where we can kind of engage in these conversations with our kind of longer appointment times, and being in a place where I think teens expect to have some of those conversations too. One strong advocacy tool that came out of Oregon Reproductive Justice Initiative was one key question. So the question being, would you like to become pregnant in the next year? And that keeps it nice and open, because it does, like I said, there are teenagers I've had that are trying to get pregnant, and so it kind of opens that conversation. Well, what is their reaction to that? How do they feel? And then it actually proposes like this algorithm that you could kind of go down. So if yes, you're exploring what are the reasons for this, and what is their understanding, and and if it's no, what are you doing currently to prevent pregnancy? So again, keeping it more of an open instead of, well, do you use condoms? And that way too, hopefully it's presented in a less judgmental way, because I can't tell you how many teenagers have told me that they use condoms 100% of the time, always, and I'm just, maybe they are, I'm just super not convinced. But I think that kind of opens up the conversation a little bit more, because then it allows you also to check their knowledge. So if they say, well, yeah, I'm using a condom consistently, well, what does that look like? Are you checking the package to make sure it's not broken before you use it? Like, how are you using it? So it engages a little bit further in letting them do the heavy lifting, almost like a teach back. So you can check, okay, you are using a method, you're using it correctly, and you know the risks and benefits of that. If they're using intermittent use, kind of exploring, are you interested in other forms of contraceptive methods, and kind of going through that algorithm there. And then if it's, I don't know, kind of exploring that ambivalence as well. So again, not that you need to have this like in your clinic room, but I think this is like a helpful algorithm if we're thinking about how can we maybe more standardize the way that we're asking about or thinking about contraception counseling to maybe remove any implicit bias we might carry into the conversation as well. And then this last mnemonic came, it was a study that, it was arguably like a very small sample size. It was only 30 participants, but it was a school-based health center, and it looked at teenagers and how they were using their knowledge, about contraceptions. And so they came up with, because we love mnemonics in medicine, it came up with the PRIME. And so these were just like the 5 key factors that they felt that students influence their contraceptive choice. So first would just be like the method preferences, so anything that they've heard from their friends or family, then references, negative and positive, information needs, so where are the gaps, where are the concerns they have, motivating circumstances to initiate, so is it someone that maybe had a lot of pregnancy scares? Do they know a teen that got pregnant, and so that's the motivating that they want to be on something, and then environmental constraints and supports. So just another kind of tool. And then just lastly, just tools and resources. One web-based resources I really like is bedsider.org that I give my patients, because it actually allows them to pull in different contraceptions and compare side by side in like a nice table. And what's nice is it's very diverse. It includes spermicide, it includes diaphragm, it includes like all these methods. So it really allows them to kind of explore at their own pace. And it actually has a provider portal as well, that you can get information, from a provider stand of view. Just some national resources and websites. The Power to Decide is where that algorithm came from, with the one question. And then social media, that Mama Dr. Jones, we didn't watch the whole clip of her, but if you do have someone that's getting their information through TikTok or through an influencer, I don't know if you want to spend hours yourself on TikTok, that sounds exhausting, but Mama Dr. Jones is an OB-GYN that does TikTok videos that are very educational, and she's actually dispelling some myths. So not trying to just solely promote her, but she's one that came across as I was doing my work through TikTok for this presentation. And then of course, like Planned Parenthood is a wonderful resource. Brooks and the Adolescent, clinic does so much like advocacy and work in our school system. And I know we have a lot of providers that have a lot of fervor as well. So with that, we made it through. So we kind of covered, recommendations for contraception, some common misconceptions with emphasis on our social media, and looked at some inequities and how can we maybe optimize our counseling and the perspective or framing of historical sterilization and contraception in the U.S. Any questions?
Yeah, so as you look at, this doesn't change, the patient perception, but as you look at like the historical context, and particularly like compulsory contraception, it looked at Black and Hispanic. You had mentioned Black and Hispanic typically are getting offered more, contraception. Did they control for number of children? Because in general, lower socioeconomic status tends to have more children. That's what's happening in Japan and the U.S. as birth rates drop with higher education. And so did they control for that piece?
I don't think they did, and I think because they used, and I was going to include this, but I don't want to just be spelling words, but they use like a reproductive justice framework. So in the sense of like a woman and their family are able to decide, how many children. So I think that is a very, because I do think, if you're having 7 children and maybe you don't have as many resources, that balance of you're not trying to force a decision, but also being realistic. So yeah, I did not, that's a great point, Dr. Drew.
Well, and I think it's all, and we don't take care of adults, or you do, sorry. But that context of, once we get over 5 children, like you can frame that. For all my patients, once we hit 5 children, I just want to make sure that I'm matching your goals, right? Like it's that framing of not just I'm trying to shove it down your throat when you have 5 children. I give that option to all my families who have 5 children. And at least as we speak with our patients, it creates more of a consistent approach, and it doesn't feel like I'm singling you out as much.
Yeah, I agree. I think, and that's what kind of, that algorithm is more so, it's not that you have to use that, but trying exactly what Dr. Drake says, trying to just be more standardized in how we're broaching things that likely are sensitive and personal information.
Yeah.
And very nice talk. Couple comments that are probably advertising. One, I thought that the birth rate incidents, or the teen pregnancy incidents, nationally and then for Virginia, and then honing in a little bit closer to that was very interesting. I'm guessing Jerry is online, probably listening in somewhere out there. But I think she's been a strong advocate talking about the Roanoke City, and you can see a nice trend there. It was a little discouraging to see a little blip up. I think it is interesting to see the state of Virginia, and we often talk about the 2 states of Virginia. We know that in some of the rural areas, I'm going to pick on Giles County in particular because we're looking that they have a very high, and I'm sure you're aware of that one, very high birth rate, or teen pregnancy rate, not birth, I said birth rate too, but teen pregnancy rate. And we're looking at ways to intervene in some of these other areas, outlying areas. And so I think it's just good there. I'll do a quick advertisement for Adolescent too, because a lot coming from the world of general pediatrics, we may have some savvy on doing some of the counseling, but we don't really offer the full services as much all the time. I think we're growing some of that, but like the LARCs and those sort of pieces. So I'm guessing that Adolescents would probably welcome us to reach out and touch base with them. And I think there's been some interest in doing that within the world of Gen Peds with Dr. Drake, and we haven't renegotiated that discussion. We need to bring that up and think about that. But very nice, thank you.
Speaking of that, do you guys do IUDs? Or
We do not do IUDs.
so it's an interesting, I guess more your experiential perception, because the AAP does recommend access to IUDs, or ideally same day. You should be able to pop in, and if you decide you want a LARC, there should be low barriers. But what is your experiential rate of teens who are wanting an IUD? I've had 1 in 9 years.
Yeah, I honestly have not. Most the next one is like they're most eager to get, and we're able, at the schools to place those. Macon does a lot of those at the school. But yeah, and then like the defo injections are quite popular, but I actually have not had, granted, I haven't been practicing long, someone with that wanting an IUD.
Yeah, okay.
I looked up the Lance's on if she's had anything else.
It's just such a low rep thing, that you're much better off, I think, in general. I think in an ideal world, they could have access to whatever they want, but it's just such a low rep thing that I think it seems that they're better served being plugged in with an adolescent OBGYN or somebody who's more comfortable seeing adolescent patients, or OBGYN who's more comfortable.
I am on, and we do well. So I'm trained in IUDs. We have trained peds residents over the years in doing IUDs. Our uptake in the younger teenage population, less than 20, has been very low. So we haven't typically wanted to start doing that in our teen clinics, and we have pretty easy access to our colleagues in GYN who are doing those on a more frequent basis. So that's where we are, but we're happy to get the peds residents trained in IUDs there. It's not hard.
Yeah. Cool. Thanks, Dr. Lance.
Yeah.
Sure.
Thank you all.
Awesome. Thank you, Dr. Laverty.